rupture of the central portion of the extensor tendon. Okay, so again, going back to that anatomy stuff, you got to take some time this weekend, right, after the shower here, and figure out what all these little anatomy components are. Take the time. You see how it's labeled there, central band? Okay, it's labeled there, central band. So that's on the extensor side, okay? So that's a rupture of the extensor tendon, the central portion, of the extensor tendon at the insertion into the middle phalanx. So the middle phalanx is going to be important because it's going to highlight why if there's a rupture there, you're going to see the deformity you see. Okay, but when you have a rupture of the central portion of the extensor tendon, the PIP will flex from the pull of the flexor tendon, right? Because the central band is disrupted, but the flexor tendon is still intact, right? The answer is yes. Okay, so we'll continue to pull. So since it pulls in a dorsal direction, and therefore the proximal phalanx heads buttonholes through that defect that's created by that rupture. Okay, again, the lateral bands are still in place. Okay, sometimes those are called collateral bands. Okay, so it's on either side of the phalanx itself of the finger. Okay, those are still intact. Okay, so as a result, the DIP joint extends and/or hyperextends. Okay, so that's what you see. You see this picture here? That is a boutonniere deformity. Okay, so sometimes when you have certain injury types, okay, and we'll get into that more today, you can see this right away, especially if it's a significant rupture, again, of that extensor side, or it can develop over time. Okay, so the affected finger partially flexed at the PIP, so that's the proximal interphalangeal joint, extended or hyperextended at the DIP. That is not an error. That's putting that to accentuate that. Again, you can see a hyperextension, but you may only see an extension initially. Okay, but again, if it's been present long enough, it tends to look more like this, and I think most of you would agree that's not just extension, right? That's a little bit more hyperextension. Okay. Bless you. Wow, it's red too. Yeah. So the deformity again can develop in 7 to 21 days. So again, that's like a huge range, right? So if you see a concern for it, you're going to watch it, and as you watch it, right, you may notice that the deformity continues to accentuate. Any questions about that? Okay. So what are you going to do? So physical exam-wise, you're going to check range of motion as part of your physical exam of both the PIP and DIP to again characterize the deformity you think is going on. So we're going to talk about a couple different deformities today. Okay, so you got to start putting these in boxes. PIP flex forward 30 degrees, and again, the DIP will be extended or hyperextended. Okay, the deformity will worsen with wrist flexion, so that puts tension on the flexor tendons. If that's what makes you understand that, okay, and I see you guys doing it, you can feel that tension, right? But the deformity again will worsen with wrist flexion. And patients who lack 15 to 20 degrees of extension of the PIP has a central slip rupture. So that's, if you have that difference in range of motion, then you already suspect, and it's a rupture of the central slip until otherwise proven. Does that make sense? Okay. And I know there was that little range of motion, that little goniometer, somebody stole it from me. But you guys saw that little goniometer I had, right? That's for the finger, okay? So you're not going to use the big honking one. You're going to use the little one and put that on the joints and see what either flexion or hyperextension you see. Okay? This kind of highlights that. Okay? As you can see, the yellow is highlighting that extension or hyperextension, and the red is highlighting the flexion. Okay? So again, you got to start burning this in your brain and understand the difference between this deformity and the ones I'm going to talk about soon. Okay, radiograph-wise, you're going to get a complete set, right? But the AP and lateral will tell you things, and it'll also tell you if there's an avulsion fracture. Remember how I told you that that's on the extensor side of the middle phalanx, right? Proximal middle phalanx. So if you see an avulsion there, you're suspecting it could be a more significant injury that could require more surgical attention, if you will. Okay. All right. So adverse outcomes of disease, right? So say somebody sustains an injury and the central slip is disrupted, right? And you know a little bit of deformity, but it goes on to become a more significant deformity. We've already talked about this. if you see this deformity here, what is the flexion and extension as we discussed, or hyperextension, do you think if the finger is stuck long enough in that position that it's going to get a flexion contracture? Yes, that's the same concept we keep talking about, right? So again, that's possible, right? So important to understand, you should get to these sooner than later, because once you get that flexion contracture, the surgery may not be the same and may not have the same results, okay? So non-operative, the good old stuff you guys know, right? NSAID, rice, activity modification. But I will tell you this, see how occupational therapy is thrown in there? Do you think they're going to potentially give you these little splints in these pictures, or fashion a custom splint for a person that there's a concern for a boot ear deformity, either pre or post-operatively? Yes, those are the people I rely on. Whenever I go to a new command, I find the occupational therapist, I find out what their favorite beer is, right? And I find out what their likes and dislikes are, because that person is going to be very important to me when I'm dealing with, I'm joking a little bit, but when I'm dealing with, managing these patients, because I can do what I do, but they do what they do, okay? So, what are you going to do as far as managing this? This is non-operative, right? You're going to put the PIP, what? In full extension, right? PIP, not the DIP, right? Because the PIP is inflection, right? In full extension for 6 weeks with the DIP free, okay? Why does it say 3 weeks for elderly patients? Because maybe you're trying to correct a deformity, and maybe you're gonna let them stiffen up a little bit wherever they lie, and not necessarily do surgery. That's what it's getting at there, okay? But for all young active duty, I put myself in that category, right? Young active duty people, you're going to treat them with a PIP in full extension for 6 weeks with the DIP free, okay? When you guys get out to phase 2, you're going to find all these different splints here that some of these are straight out of the box. They come in different sizes for different fingers, right? If you look at your hand, you see your fingers are different sizes. Therefore, a box has multiple sizes, and you have the sizes of the patient. Okay, so when you get out to phase 2, I implore you guys, when you're out there in orthopedic rotation, sports medicine rotation, and you see these patients are being treated, get into it. Try to figure out how to use these splints. Because guess what you're going to be doing when you get out to these BASs and these family practice settings? You're going to be doing this stuff yourself. So you got to sort that out in phase 2, okay? So do it. Operative, non-operative treatment failure, or persistent deformity. Okay, persistent deformity more so, right? Because you guys did the right thing. You did the non-operative care. But persistent deformity is, say somebody does a late presentation. There's a person in here, at least one person here, right, that has a funky, crooked finger. Because they didn't go to medical initially, and the deformity set in. They got a contracture, either it's flexion or extension, and their finger just healed that way. Okay, that's what we're trying to prevent. But once it gets to that point, that splinting stuff, you can't move that flexion contracture with a splint, right? You need to get in there and do the Lord's work and fix it. Okay? Good to go? Okay, adverse outcomes of disease, obviously they're going to not be able to achieve full what? Extension, right? Because they're in flexion. That makes sense. Residual PIP flexion deformity, okay? So that can occur whether or not you do treatment sometimes, but it's more a risk if you don't do the right treatment. And do you think time is a factor here, like I keep talking about, with multiple injuries? Yes, because again, things want to stiffen, and stiffness is the enemy of orthopedics, okay? And fingers don't like stiffness, okay? Referral decisions in general, you try to do the right thing, you don't notice that the patient's improving, or let's say they're non-compliant, right? They're not improving, for whatever reason they're not improving, you're gonna refer them, okay? Residual deformity, despite, again, successful treatment, or the appropriate treatment, I should say, they have a residual deformity, okay? Any questions about that? So again, when you guys start going through, we're gonna talk about mallet finger today too, okay? When we start talking about these different deformities, understand what's going on at the PIP, the DIP, is it on the flexor side, is it on the extensor side? What is the mechanism of injury that occurs, okay? And you'll be able to key in on these a little bit more. Carpal tunnel syndrome, we should be able to get through this pretty quickly because you guys have had a lot of these components already, right? You guys talk about carpal tunnel in sophomore year a little bit, okay? So we'll talk specifically about the special exam, or special testing as well, okay? So carpal tunnel by definition, it's median nerve entrapment at the wrist. That's that carpal tunnel, and it's a syndrome. So the patient can have multiple symptoms, right? And I already told you guys, don't fall into that trap where you see CTS abbreviated and you assume it's carpal tunnel. Make sure it's not cubital tunnel. That's why I always write it out. I don't abbreviate it. That way people know this is what it is, okay? Is it the most common upper extremity compression syndrome? It is. Do you think it's very commonly tested? It is, right? So I would know this, okay? It most commonly affects middle-aged or pregnant women. So middle-aged pregnant women, oh my goodness, right? So, but yeah, I will tell you this, when it comes to carpal tunnel, it's just going to be occupationally based sometimes as well. Do you think doing a lot of activities that put your wrists in extension for long periods of time, or flexion for long periods of time, or both intermittently? Yes. So it can be very occupationally related as well. So again, as good clinicians, you all guys are always going to be good MLS, good sense of what they do for a living, right? Do people that type a lot have carpal tunnel? Yes, they do. Okay? All right, so what causes it? There's a list there, right? I just explained to you kind of from an orthopedic standpoint what we usually see, right? RA, carpal tunnel, is usually treated by, bless you, by rheumatologists. Okay, tumors, got to go after it, right? So that's more specialized. Pregnancy, you'll get referrals from OBGYN, Women's Health, and they'll refer back to you to say, hey, I don't do injections, you manage it, right? So if you get trained on them and you feel comfortable doing them, then do them. Otherwise, you send them to me, and I do them, okay? There's the diabetes, right? Diabetes is everywhere, and it causes everything, right? All the bad stuff. So diabetes has a high correlation as well, okay? So I see a lot of that. Thyroid dysfunction, sure, right? Any kind of endocrine dysfunction. You guys have you guys talked about thyroid stuff yet, endocrine? You're not, okay, so I will hold that. But you will learn a little bit more about that in the whys, okay? But again, anything that puts the body into a pro-inflammatory state or an imbalance hormonally can cause this, okay? All right, anybody have any questions about this diagram here? It's just showing the carpal tunnel, right? And you see where the median nerve is, that yellow circle there? That's a transection of the median nerve. Okay? So the test that we do to see if we can compress that, if we can put pressure there, and see if we can reproduce the symptoms that the patient is saying they're having. Okay? So remember I told you guys, make sure you understand the difference between hypothenar and thenar, right? Because this is thenar, correct? Okay, so this is thenar atrophy and severe long-standing compression, like we talked about. As you can see, that looks like it's wasted, right? That's what we call it, muscle wasting, right? Atrophy, right? So it doesn't look, the muscle bulk and tone there is not as prominent as it is on the unaffected side. Good to go? Is it more common on the dominant side? It is. So is that the right hand? It is. Are most people right-handed? They are. So again, important to get hand dominance because it can lead you to make different decisions. Okay? And I'm going to ask you on the phone if you call me. Okay? So where's that distribution for median nerve? This is beating a dead horse, I hope, at this point. Thumb, index, and long finger. Okay? And a portion of the long finger, correct? Not the entire long finger. Okay, so make sure you understand that physical exam because you're going to ask the patient, where are you experiencing this numbness and tingling? And they're going to tell you, and you got to correlate that in your mind. Okay, but you guys are going to be masters of anatomy and physiology, so no worries. Positional in nature, again, they tell you that they have increased symptoms when they're doing prolonged typing, when they're going into prolonged push-ups position, right, doing a lot of push-ups, hill climbers, suicides, whatever, then you'll note that, okay? Symptoms can be worse at night. Why do you think? Because do some people sleep all kind of contorted and bundled up and almost in a fetal position? Yes. People have different positions they sleep in. They're in that position for 6 to 8 hours. You guys are all getting 6 to 8 hours of sleep, right? Yeah, of course you are. But I'm just saying, they're in that position for long periods of time and they're not able to self-correct. So they'll say, oh, I wake up in the morning and I just feel that heaviness in my fingers, that numbness and tingling, right? If it's bad enough, do you think it might wake them up in their sleep? Yeah, so take note of that as well. So they'll say that they try to shake out their hands, right? I almost threw my pointer. They shake out their hands, rub their hands to kind of try to get rid of that, get that circulation back, get that feeling back, the sensation back. Okay? Persistent numbness, again, is something, and especially weakness, is something that's present in long-standing disease, right? The long-standing pathology, right? And like I keep telling you guys, you always ask them and say, well, what kind of activities can't you do, right? They might tell you they have a difficulty turning a doorknob, or they have difficulty holding something in their hand. Okay, so that's important to note as well, because I can denote that they have weakness. Okay? All right, so physical exam. We're going to go through this today. Valence test. You guys have had this already? No? Yes? Not really? No? Okay. So a valence test. Everybody sees how I'm doing right now? Right? So the reason I'm doing it like this is because I'm trying to get them to maximally flex at the wrist and to cause compression. All right? So if everybody goes into this position, you're basically going to tell them to take the palms of both hands, right? I'm sorry, the dorsal aspect of both hands, and push them against each other, right? And do you feel how that puts more compression there? So it's not just doing this, right? This is lazy, right? You try to get them to actually go up, 90-90 if you will, right? And push against their hands, okay? One hand against the other, right? And cause that compression, okay? So that is appropriate valence. Oh, I got one, right? That's the appropriate valence test, right? So if they do it at their chest, that's fine, but I will tell you that most people have to elevate higher up to get that full compression, but you're trying to do maximal compression. Okay, that's the whole point. So if somebody's doing that weak thing where we're just doing this, right, that's not enough. Well, a lot of times they got to bring it up either to nipple line or higher. Okay? We'll talk about that more later on. Okay? All right, so that's valence test, Tinel sign. Okay, Tinel sign, we had a Tinel sign for the elbow, right? All right, so was the Tinel sign that tappy, not the guitar strumming, right? Not the twanging, but the tapping. Okay, so basically what you're going to do is you're going to go back to this tunnel here, right? And you're going to tap over that tunnel. I will tell you this, the carpal tunnel is more distal than you think. Okay, it's not proximal to the ulnar styloid, right, or the radial styloid necessarily, but the ulnar styloid is more appropriate to say. It's more distal than you think, so it's actually in the palm. Everybody sees where I'm compressing now, right? Where I'm pointing, excuse me. Okay, so that tappy tap is kind of the distribution going distally. Okay, so you start proximally and work your way distally, right? Make sense? Okay, so it's more distal than you think. Okay, so that's also called a Durkin's sign. Okay, so I know a lot of names, right? Sometimes the Durkin's sign is also called carpal compression test because you'll do both, right? So I think Durkin's is actually more commonly used for Durkin's, but they're used interchangeably in practice. Okay, so the compression, remember how I told you that area more distal in the palm, right? You're going to actually cause compression of the median nerve, and that's all you're doing there. So again, that correlates to the compression test at the elbow that you do on the ulnar nerve, right? The difference being here is that it's the median nerve. Make sense? But the principles are the same. Okay? So when you're doing these tests, right, do you think you're going to ask the patient, tell me when you feel, what you feel, and where you feel it? The answer is yes, right? If you tell a patient to tell you when they feel numbness and tingling, what are they going to feel? Numbness and tingling, right? So again, make sure you kind of ask opening questions, but give them some kind of a multiple choice, if you will. Okay? Any questions about that in general broad sense? We'll go through that again in the lab today, okay? 2-point discrimination. You guys have not had the neuro yet, right? So 2-point discrimination is basically your ability at the fingertip only to discriminate between 1 point and 2 points. Okay, it's just what it sounds like. Okay, so you can use as a gross measure. Right, I already told you what 1 centimeter is. Right, it's the width of your small finger nail. Okay, so usually it's to 5 millimeters. So it's half that width. Right, so you can take a paper clip, unwind it, make 2 points. Measure it out to 5 millimeters and see if they have 5 millimeters or less. They're able to discriminate when you tappy tap on their fingertip. Can they tell the difference between 1 point and 2 point? Should you tell the patient to look away as you're doing this test? Yes. Should you not give them guiding questions? Yes. You just want to get a sense of like, are they feeling 1 point or 2 point? Are you doing that across all the fingers and comparing it to the other side as well? The answer is yes. Okay, and you guys will go through that a little bit more in neuro. I will not test you on the 2-point discrimination in my course, just knowing that if you're given a result, right, that says it's greater than 5 millimeters, is that normal or abnormal? That's abnormal, right? So just take that clinical picture, right, and add it to whatever it is that's being informed. Make sense? All right, that's all I expect you guys to know for now. Good to go? Any questions about Phelan's, Tinel's, or carpal compression test, otherwise known as Durkin's, DHURKAN posture test? Okay. Okay. All right. So here we go again. So is this a compression? It causes paresthesias distally, and you can have a mixed clinical picture if they have neck pain. Oh, and by the way, their shoulder hurts. Oh, of course, their elbow hurts. Oh, and by the way, they're diabetic. So what test can you get to discriminate between peripheral neuropathies, radiculopathies, and compression, right? EMG and CS. Okay? Again, I hope you guys are getting the sense that if you're not ordering these a lot, in certain patient populations, like old dudes like me, you're probably not getting the full picture. Okay? That makes sense? But it says rarely required for diagnosis. Okay. Because guess what? You know that they have symptoms going from their wrist to their fingertips. Right? It's not quite as complicated, but that's if it's isolated. If you have a mixed clinical picture, a lot of times you will need one, okay, to discern the difference. Okay, makes sense? And what radiographs are you going to get? You're going to get all the radiographs, okay? Is there anything you're going to see on there? No, this is all soft tissue stuff. It's compression, it's nerves, right? So you don't expect to see much on there, but if you see a bony projection, right, in the part that's projecting and compressing into the carpal tunnel due to osteoarthritis or something like that, then you'll take note of that, but usually they're normal, okay? Any questions about diagnostics for this? Okay. What are you going to, yes, sir?
So even though it says it's not diagnostic,
Yes.
Like for a patient, if they want to get any further diagnostics or further testing, does this help them out as far as like for the other people down the road to check those boxes for them? So,
I like this question. Did anybody hear that? So basically he said, someone like me, right, when you send it to me and you say, I've done all the conservative care, do I prefer to have you, and see, I'm paraphrasing, do I prefer to have an EMG and CS if you send it to me for surgical consideration? Yes, I do, because then that gets right to it, right? I can either offer an injection or I can offer surgery, okay? So I will tell you that from a primary care standpoint, it may say that you don't need to make the diagnosis, but that's because we all assume, and we know, right, that you guys are going to be good at doing physical exams, so you'll be able to nail this down, okay? But again, if you want to do more, especially invasive care, let's say injections versus surgery, then it is, to answer your question, it is beneficial to get that test, and that kind of nails it. You can say, I nailed it, right? I got it. I know this is 100% median nerve and no ulnar nerve involvement. Does that make sense? Okay? Because let me just break it down. Did I answer your question? Okay, good. He's got another question loading. Yeah, so thank you. I appreciate it. Yeah, but do you think, let me just break this down too. When you do an EMG NCS, do you only get one nerve? No. The EMG NCS, they test multiple nerve distributions. Ulnar, median, and radial, right? So it gives you a lot of information. So again, if I haven't had that before, there you go. Okay? So if that's long-standing compression, long-standing pathology, can they have permanent loss of sensation? 100%. Okay, so you want to avoid that whenever possible. Duh. Right? So when you're talking about conservative care here, everything else is the same, but then you start adding splinting in a neutral position. Does everybody know what a cockback wrist splint is? You guys have seen people walking around the exchange, recruits that are faking it, walking around with these wrist braces, right? And it's just the wrist ends about here, right about the mid forearm, and it has their wrist in kind of it's called a cockback for a reason, right? Do you guys have ever heard the beer can position, the neutral beer can position, or Coke can, I should say, right? So this is a position of neutrality for your wrist, okay? And that's what the splint does. It's got a little bit of a cock back, right, to put the wrist in this position. Okay, so that's what they mean by a neutral position, okay? And so you're putting the patient in that, right? You put them in there pretty consistently initially, and then you kind of wean them back. wean them back as their symptoms improve, right? Do you tell them to wear that at night when they're sleeping? Yes, right? Because again, they're going to contort, put themselves in all these weird positions. So this one that's going to be shown here, this is not an off-the-shelf one, right? This is a custom one. Again, OT can be your best friend, right? You see how it's not circumferential? They can allow the person to do their daily activities a little bit better. So if you have that capability, certainly use it. Okay. Proper ergonomics. What do we mean by that? If you're talk about like posture when you're sitting at your desk, your wrist positions. Again, keep them in a neutral position. No hyperextension, no hyperflexion, and just proper body mechanics. Essentially, is what they mean by that. Is OT really good about teaching people that stuff too? They are. Okay. So again, OT can be very beneficial. Steroid injections, if above fail, okay, I will tell you this, when you're injecting a steroid into that carpal tunnel, is there like an artery near there too, or a couple of them? Yes. Is there other nerves around there? Yes. Are there other things that you shouldn't stick a needle into? Absolutely 100%, right? You should stick the needle into the carpal tunnel, not into any of the aforementioned structures. So if you've been trained, you feel comfortable doing them, great. We do them all the time, okay? So again, we're your resource if you're like, I think they're at that point. Good to go? Okay. All right, operative, always, right? Operative is non-operative treatment failure with the exception of a few ones I talk about, like distal bicep tendon ruptures, right? All right. So sensory loss or weakness of theater muscles, I mean, if you see that, you should be sending them to me pretty quick. Okay? Make sense? Tappy tap? Okay. He's excited. All right, so what do? So we release the carpal tunnel. Okay, so there's a band of tissue that goes across that tunnel, kind of like a sling, if you will. I'll introduce that concept, right? And that causes everything to kind of stay where it should be, right? So, but it can also cause compression if there is a compressive component present, so we'll release that band of tissue. You see what that picture is showing you there? This is showing arthroscopically. Okay, that's what the hand surgeons do. They just put a little camera, put a little instrument, do it. But, we can make an incision and just go in there and release it, close it back up, put them in a nice, comfortable soft tissue dressing, plus or minus a splint. That's a discussion for the surgeon. And then they can go about their lives, okay? So adverse outcomes of treatment, anytime there's surgery, there's a chance of infection, right? With self-infection, usually very minimal, all right? You guys will learn in the future. And when it comes to hand stuff, the post-operative infection rates are low. Okay, the hand is very vascular. Okay, persistent symptoms, sure. You go in there, you release it, but they have persistent symptoms, right? It could be due to a number of reasons. It could be due to an incomplete release, things that were missed. Like I said, it could be osteophytes that are causing compression and they weren't addressed, or it could be due to the fact that you didn't get an EMG or conduction study and realized that they also have cubital tunnel. So they still have. So now their median nerve stuff is good. But they continue to have other peripheral symptoms, numbness and tingling. Make sense? Okay, so you may see that. Okay, so you start over again and you keep working them up. Okay, so what are you guys going to do? So somebody comes in, you suspect they have carpal tunnel, right? But it's not that serious. It's early on, right? And they fit that clinical picture I described earlier, where they're doing a lot of repetitive activities or putting their wrist in hyperflexion, hyperextension. You treat them for 3 months. They get a little better, but it doesn't quite go away, or their symptoms continue to worsen. After 3 months, you're going to send them to operative specialty, right? Orthopedic surgery. Does general surgery do these sometimes? There is some general surgery bleed into that, but I'll tell you, I teach you just orthopedic surgery because we have the hand surgeons 100%. Okay? Make sense? So that bottom there is, again, reiterating everything I've said. Any questions about that? How are you going to manage these patients? Do you think there may be a question on how to manage these patients? Sir?
So if we see the atrophy, can we just call therapy if
that's in a perfect world kind of answer, right? So his question was, you see a patient with theater atrophy, right, long-standing disease, long-standing numbness and tingling. Should you get the EMG nerve conduction study, or can you just send it? I will tell you that you can just send it, right? Right? You can, right? It's reasonable because again, I've told you should, right? Right? So I think that's reasonable. But if you can get the EMG nerve conduction study on the way to see us, because no one dies from this, right? right? So we're not gonna necessarily see this tomorrow, but if you can get an EMG SCS in the meantime, it's not a bad consideration, makes sense? But for the purposes of testing today, I will tell you that once you see that theater atrophy, right, and the persistent numbness and tingling, it warrants a surgical evaluation. Did I answer your question? Okay, good. Now, if you send it to me, again, I will figure out what your favorite beer is. I have to get send the patients with the right workup, and this just shows that you know what's going on, right? But again, is it necessary to confirm the diagnosis? The slide says no, correct? Okay, yeah, it's kind of out of the bag. We know what nerves run into the theater eminence, right? What causes atrophy if it's compressed. Make sense? Okay. We're going to get them anyways, but I'm just going off the book. Okay, DQ tenosynovitis, decurvain tenosynovitis. So this, do you think it's a tendon and a synovial capsule with fluid, synovial fluid in it, and an itis, which is inflammation? The answer is yes, right? Because we know this. But this is going back to that concept we talked about in our lab. Not lab. Well, it is a lab. It's labeled as lab. But in our discussion about relevant anatomy, right, on review, and then I talked about the first dorsal compartment and the fact that what two tendons live in the first dorsal compartment. You guys read really well. Congratulations. But adductor pollicis longus, extensor pollicis brevis, right? So APL, EPB. I can encourage you to say them, not abbreviate them when you're in phase 2 because it shows that you know. Okay? But those are the two things we're talking about. There are multiple compartments in the wrist. The only one we're talking about here is the first dorsal compartment. Okay? And I also mentioned at some point, whether you remember it or not, that is there sometimes a bleed over and trying to figure out if this is snuff box tenderness or first dorsal compartment tenderness? There is, right? But you would agree that the snuff box is more distal to the radial styloid and that the first dorsal compartment is more proximal to the radial styloid, correct? But they may complain, their complaint may be radial sided wrist pain. That may be their initial complaint. So you got to figure out where that pain is, right? What do you think is going on? Everybody get that? Radial sided wrist pain? Okay, so radial sided wrist pain, that means you're forming a differential diagnosis based on that, correct? And the presence or absence of any kind of trauma. Okay? Causes pain, swelling, triggering as patient moves the thumb. Well, that makes sense, right? If they're moving the thumb, that makes sense. So, what kind of patients are you going to see that with this? Again, we're going to get targeted, right? And especially what? Postpartum, right? I don't want to get any rock star out of me, but altered hormonal states and repetitive ulnar deviation. Do we know what ulnar deviation is? Okay, so ulnar deviation, right? Radial deviation, okay? Right, so sometimes if you just do it like this, it makes more sense, right? Whichever way you're going. Okay, do you feel like it's going to put more stretch to go away from the thumb, on the thumb, and the first dorsal compartment? Yes, that's why. Okay, we'll talk about a test today where we're going to do ulnar deviation, right? To test for this and see if that test is positive. Okay, good to go. Any questions about the anatomy here? Okay. Radial sided wrist pain and or swelling. Very commonly, the swelling is intermittent. It kind of comes and goes. They may have a direct tenderness over the radial styloid, but not the snuff box, the anatomic snuff box. Okay, if it's bad enough, they'll hurt everywhere. I get it. But again, it tends to be more radial styloid. Pain with moving the thumb or making the fist, and the tendon may actually creak. Okay, I've actually seen this and heard this. Okay, it creaks. The patient will say, "I hear it creaking." Okay, so just kind of a grinding, grating sensation of that tendon that's just moving. Okay, and again, going into what? Ulnar deviation. Okay, and making the fist. Okay, makes sense. Has anybody in this room ever had DQ tenosynovitis? You have? Okay. It sucks, right? Yeah, it kind of comes and goes, right? And that's the clinical picture with this. You treat it, and they come back, right? So, all right. Tenderness on physical exam. You're going to have tenderness over the first dorsal compartment, not the anatomic snuff box, not, and again, we talk about the CMC grind test, right? So there's a crossover. You'll do the CMC grind test to see if you think this is first CMC osteoarthritis or if this is truly DQ tendinosynovitis, decurving tendinosynovitis. Okay? There's that crepitus again with flexion extension, right? And a positive Finkelstein test. Okay? I love saying that word, Finkelstein test. Okay? So everybody, all right, awake from your slumber, and do me a favor, extend your arm. Okay? Fully extend, thumb up like this. Take your thumb, put it into your palm. Close your fingers around your thumb, and now, like a hammer, go ahead and ulnarly deviate. You feel that stretch there? Okay? That is the proper way of doing a Finkelstein test. Okay? And it is not flexion. It is ulnar deviation. When you end up in that position where you're going downwards on the hammer, right? Rotate your wrist and see where you're at. You're in ulnar deviation. You see the rookie mistake people make? They think that's flexion. It's actually ulnar deviation. So again, you're reproducing that motion that causes them that pain and putting the stretch on the first dorsal compartment. Make sense? Do you have to have the arm fully extended? No, you don't. You can have it like, at 90 degrees here, but just make sure that, again, you kind of walk them through it and they're not doing this craziness where they're doing this, right? This is not the way. It's not Cobra Kai, right? It's ulnar deviation we're trying to accomplish, right? Make sense? Okay, we good with that? Okay, we're going to practice that today, 100%. And it sucks, right? Even if you don't have DQ tendonitis, you probably didn't like that, right? Yeah. So even if it's not DQ tendonitis, it's not pleasant. But what you're looking for is a significant reaction to that that reproduces the symptoms that they're reporting. Make sense? Okay. All right, good. Round of applause for everybody. All right, so, yes, thank you. Thank you. Thank you for playing well. All right, so imaging-wise, you're going to get imaging. Why do you get imaging? I just told you it's first dorsal compartment, APL, EPB. All right, great. All right, so it's all soft tissue stuff, right? Now, if you see some kind of bony abnormality, could it be causing compression as well? Absolutely 100%. I keep saying that, right? And these are some examples here. Deformed radiostyloid. How do people get that? There are some congenital conditions that cause that. You can get that due to osteoarthritis, so again, repetitive wear and tear, right? You can have calcifications there. We talked about HO, a very specific one that's generally related to surgery. But your body can just decide to make calcium deposits wherever the heck it wants, right? And again, getting to OA. You're going to see OA the rest of your career, and you're going to be like, is this OA or is it something else? Right? The reality is you treat, in this case, DQ tendonitis a certain way, and when the treatment fails, you send them to me. Or us, I should say. You got to stop saying me. All right, so chronic outcomes of disease, this is if you do nothing, and sometimes if you do something. Chronic pain, okay, great, it hurts, because it's going to keep hurting. Weakness, well, do you think they're going to have weakness and potentially stiffness from not wanting to ultimately deviate anymore? Absolutely 100%. All right, so there's that decreased range of motion. Tendon rupture is possible, but super rare, right? You're talking about long-standing degeneration of the tendon itself, and then possibly a rupture. Can you sometimes see that, though, with, like, RA? Sure. Again, RA, who hates you? You, right? So there you go. So anything's possible, okay? All right, so we keep talking about this thumb involvement, right? I described to you a cockback splint. Do you think a cockback splint has any play here with DQ tendonitis? No, that's carpal tunnel syndrome, right? Okay, so with DQ tendonitis, you want to use a thumb spica splint, okay? Because that incorporates the thumb, doesn't allow them to go into that Finkelstein position, right? It doesn't allow the thumb to do a lot of range of motion, right? And it does some soft tissue rest. Make sense? So for DQ tendonitis, decurving tendonitis, you want to use the thumb spica splint, often abbreviated TSS if you see it in the chart. Okay? Now, if you're going to do an injection, you see this picture down here? Right? Do you think that's injecting into the sheath and not the tendon itself? The answer, of course, is yes. Right? So you want to do a flexor tendon sheath injection. We do those all the time. If you're comfortable with them, bless you. She's fanning herself with it too. So if you want to do these in clinic and you feel comfortable with them, great. Just don't stab the APL, EPB. The patients don't like that. Okay. Right. There's your landmarks here, by the way. Oh, and by the way, that's also the landmarks if we decide to go do surgery. You see that curvy S wavy line there? That's our incision area. That's where we do the Lord's work, right? And we release that compartment. You remember how we were talking about when we talk about acute compartment syndrome, we release compartments? This is a compartment, right? It's being compressed. So you think if they have long-standing compression that doesn't respond to non-operative treatment, then we go in there and do basically the same thing, where we open up the compartment and make sure everything's free-flowing. Right? There's no more compression. Yes. Okay? And you try to get a complete release. That's why that's also called a compartment release. Okay? But usually they don't get there again until they've done non-operative treatment for it. Okay? Do you mind me asking, have you had surgery for it? You have not? Okay. All right, so I can sign you up. Good. All right, so radial nerve, sensory nerve injury with injection or surgery. All right, going back to this picture, what nerve are we playing with here? Radial nerve, specifically the superficial branch of the radial nerve. Okay, that's more on the thumb side. Okay, you guys see that area where it says SPRN, superficial radial nerve. Okay, that branch. Okay, so you don't want to go poke it in and around there if you don't know what you're doing. Okay, and we don't want to transect that if we do surgery either. Okay, so we will identify it, move it out of the way, and when you do your injection technique, you'll know how to avoid it. Right? So basically, you just aim more radially, and you should avoid it. Okay, but we won't get into that today. We'll talk about that later. Okay, all right. So what nerve? Radial nerve. All right. Failure. There's that 3 months again, just to be consistent, right? You do everything you can. All right. Patient comes back. You want to ask them, are you wearing your thumb spiker splint? Are you wearing it? Most of the time, if not all the time. Are you doing any kind of stretching activities? I would tell you that OT for this doesn't really help too much. We don't really talk about that too much. It's more rest, ice compression, elevation. Have you done OT? Do you mind me asking? You have not done it? No. Just rest, right? Yeah. I will send people if they ask, right? But it doesn't. I don't know. It just doesn't really. Literature doesn't really state that it does much good. Okay. But if they want to do it, and also by the way, if you want to get a custom thumb spiker splint too, right? Instead of a big bulky one that includes your entire wrist and into the forearm, right? Something a little bit easier to use at work. Doesn't look as like prominent in uniform. Okay, so there you go. So referral decisions, persistent numbness, weakness, the inner muscle atrophy. Okay, again, you get that atrophy, you know you got some compression going on. Okay, flushing. Feature on red too. Yeah. So all right. So this is a good breaking point. Let's take a break. We'll continue.
Dude, no, semester break, dude, we're going. We're gonna cut down the days for semester break. How many days? You guys want to hear how many days till graduation?
Which graduation?
No, graduate. 602 days. I don't think so.
He's breaking smart too. I use like I know.
Ah.
Did I answer your question?
Yes.
Okay. I get kind of like.
You're good.
It's the same conversation with Paul on the phone next year.
I think I have a diagnosis for health. But that's crazy because I went to ORTHO and then ORTHO's like, we don't know what you have. You're crazy. I was like,
That is true.
but it's like literally, I remember because it happened, and I was like, oh, like, they found out I have a game going, we're doing an X-ray. It's like, oh, you have a game going right here. I was like, my pain is not here, my pain is here. It's right here. And they did that exact test. So I went to physical therapy, she gave me a bunch of exercises, and that didn't work at all. And then she sent me to ortho, an X-ray. He's like, yeah, it's probably the ganglion. I was like, but the ganglion is over there. And that's not where the ganglion is. He's like, well, I don't know exactly. I was like, gave me a little yeah. 2 years later. Like this. I had to do this my face. He was like, you want to put that? I was like, how can I help you? This is not surgical. You don't want to profile.
And that's because
Sorry.
You have to go 2 ways.
Yeah, she made it seem like there'd be way more math on there.
I hope she gets that for sure.
Usually lights up when you start the actual clock. Like, yeah.
That's my. We're watching, right? First time. That's my pin, and I know for sure. Never change.
Lock out, yeah.
I'm telling you, every time I try to use it, oh no, it worked. Guys, it's happened 3 times.
Make sure you put like an extra space or something or some capital. It doesn't like
Okay, teleport.
Be back. It's about 6.
okay, but we're gonna. You won't see the actual image, you see the radiology.
See, there's my the contact. That's it.
Just for Did I get there?
We'll look at that.
I would have ran away.
Wait, but that's not.
Go to clinical reports and then go to radiology. And then click down and look at radiology.
Yeah. Yeah. Yeah.
If you have an injection or anything, like call up. If you go in for a shot, it's
Yeah, I don't know.
Are you looking at the X-ray or are you looking at the spider? Go to clinical report. You're on the wrong one. And then on the drop down, hit radiology.
Oh, man, I wrote it all down. Yeah.
It said girl's crazy. Get fucked.
Girl.
Rumor mill.
Reverse like.
So before you
Up to the alcohol. That. I don't know what it was. Right. I still remember
I'll make it.
Yeah, who's that?
Yeah, what is this?
If they don't restart the computer, it does this. So, I will find out. Alright, So we're gonna keep pushing, okay? You guys got a nice little bit of a break. Let's keep pushing. All right. So putrid's contracture, a word that I very commonly misspell, by the way. So it's DUPUY, D-U-P-U-Y, but I still misspell it. DUPUY is actually an ortho company, but again, I still misspell it, right? But this is putrid's contracture, okay? So it's a putrid's contracture. I want to teach you guys something, okay? Everybody kind of knows what a trigger finger is, maybe, sort of. Right? You guys talk about trigger fingers yet? No, you did not. Okay. So a trigger finger, everybody knows what a trigger is, right? You know your trigger finger, right? So you're doing that, right? All right. So that's what we're talking about when it comes to trigger finger. Is more of this. With the putrid's contracture, right? I have one. I'll do show and tell later on in lab. Okay. So the putrid's contracture is actually more proximal to where the trigger actually occurs. Okay. So can it have triggering as well? Sure. But the putrid's contracture is in your palm more so, in the palmar fascia, right? And so that's, when you think about the putrid's, think about where I'm pointing more so than at your finger crease, right? At your PQ crease, if you will. All right? And that's just in general broad sense. Now we'll get into it. You see how they're talking about that contracture that's in the palm and more proximal to the crease of your fingers? If you do this like this, right, crease your fingers and do the kobakai, right, and you put your hand in this position, if you now look at your palm, that dorsal palmar crease, right, that's just proximal to your MCPs, right, or at your MCPs, that's where the trigger fingers occur, okay? Now, the putrid, again, is more in your palm. As it says there, it's a thickening and contraction of the palmar fascia, okay? So don't get those confused, okay? Because people very commonly confuse putrid's, right, with trigger finger. Can you get triggered with putrid's? Sure. Don't go reading a bunch of other stuff, right? But this is contracture. So what I'm concerned about in my age, right, the fact that I still like to operate, is my ability to grasp, right, instruments and do things. So I don't want that contracture to cause my finger to flex down, right? Like this, and be stuck in that position. That's awkward when you're doing surgery, right? So that's what I keep an eye on, and I do my stretches, right? This is not the pew-pew thing with the trigger finger, okay? If you remember nothing else, remember palmar fascia, okay? I know you guys are laughing at me, not with me. I get it. So is it associated with certain conditions? Absolutely. The diabetes. There we go again. Guys, you guys are going to hate diabetes, okay? All right, but the patients with diabetes hate it too, so it's whatever. So alcoholism, smoking, is smoking cause a pro-inflammatory condition and distal pro-inflammation or inflammation? Yes, 100%. So again, these are all the bad things, right? Repetitive trauma, vibration. Ooh, okay, there we go. Remember we talked about the jackhammer guy? The guy that was operating the jackhammer and all that stuff? So repetitive, vibration can occur, that thickening and contraction of the palmar fascia again. Right? You'll never forget it. You see that position there? Do you think that if my hand looked like that, I could do surgery? No. Yeah. Okay, so that's what I'm worried about. I'm keeping an eye on it. My father had it as well. There's a strong genetic component to it. So I just keep an eye on it and see if I need to have something done about it. Because I like to make money. Right? So anyways, but there's that term distal palmar crease. I explained to you what that distal palmar crease is, correct? So you guys all know how to find it. If you do not, ask me at the lab. I'll explain it to you again. But if you make the kobakai, you rotate your hand, look at your palm, it's that distal crease at the MCP essentially. Okay? Good to go? Yes? Okay. Good. Ring finger most common. Okay? Why is the ring finger most common? Let's get this out of the way. So for most people, don't show me your alien hands, I'm not interested. Okay, but for most people, your middle finger is your longest finger. You go like this, you're like, huh, it is. But take your fingers and gently and slowly curl them a little bit, right? And you'll see, right, when you get to about the position I'm in now, that your ring finger is actually more prominent. Keep going. See how your ring finger is a little bit more prominent? Okay? So that's why when you catch your fingers, when you're reaching out for a jersey, you guys learned about jersey finger, right? What's the most common digit? The ring finger. That's why. Because when you go reaching for that jersey, Bowen, right, he struck that child on the playground, hold on, right? So you go reaching for that jersey to catch him as he's running away with his lollipop, right? Then you catch your finger, it's usually the middle finger. Because again, the fingers are curled. Does that make sense? Okay, that's why, do I keep telling you guys? I know some people are like, I can't get there. I'm not interested in your alien hand, okay? Let's go through it in lab, and I'll convince you, hopefully, or use someone else as a dummy. Excuse me, as a test subject. Okay, so, but that's why, okay? So like I was just saying, when you ask people what position their hand was in the injury, is that because of things like this? Yes, right? So again, we will ask that question very commonly when it comes to hand injuries, okay? Followed by the little, long thumb and index finger, okay? Notice it doesn't say pinky, right? Long is confusing because that's the middle finger. Again, I just explained to you why the ring finger is more common for these type of injuries, okay? MCP contracture, okay? So again, if it's proximal to the MCP, do you think as they curve down, they're going to have contracture? Yes. They're going to have the inability to grasp or grab onto things, okay? Do they also have an inability to put a glove on? Can you put a glove on with a hand like that? No. Remember that when you take pants. You're welcome. Sensation is usually normal though. Does this have anything to do with any kind of sensory thing, or is this the palmar fascia? Fascia, right? So again, your sensory exam is normally normal. Normally normal. Is not abnormal. Whichever one. But you see that contracture there, as it looks like that. When you see it like that, I should say, we call that a chord. Okay, it's almost like a guitar chord, right? Guitar string. Okay, so that's a chord. It's a thickening, right? And then if you have what I have, I don't have a chord. I have a nodule. It's a nice, well circumscribed, kind of round feeling lump, if you will, right? I actually have a nodule. Okay, so that's the difference between those two. But they can both cause finger contractures. Okay, so I want you to remember palmar fascia, and I want you to remember contracture, and I want you to remember that usually the neurological exam is normal. Okay, because then you're not worried about other things. However, then we talk about how patients with diabetes have these sometimes. Can they have peripheral neuropathy? Sure. I'm talking about as it pertains to this condition itself. Peripheral neuropathy in those cases is due to the blood, the blood sugars, okay, and other things. Good to go. Contracture, limited hand function, sure. We talked about that. Remember the gloved hand, right? You have an inability to put a glove on that hand, okay? So, therapy-wise, okay, splinting, but it's night splinting, okay? So those splints are very specific, okay? Those are palmar splints, okay? You will send them to OT to get those. Those usually are not off the shelf, okay? You will not confuse these. You see this here? You think you can find something like that off the shelf? No. You got to make that specific to the patient, okay? And so the point of those splints is to try to get progressive extension of that flexion that is occurring due to the nodules or cords that have formed. Good to go? Understand? Okay? So that's the purpose of the splint. And you do it at night because that's when people are most compliant. Okay? Collagenase injections into the involved cord. Won't get into that. I've actually looked into that. The military doesn't really do those. Those injections are expensive. Okay? But that's the only thing in clinical studies has been shown to make any kind of difference in the progression. Okay, so hopefully, I can find a sponsor to pay for it because they're expensive. All right. So, operative indications. I try to break it down. MCP 30, PIP 10. MCP 30, PIP 10. PIP 10, MCP 30. Okay? Because this is the point where you're going to look at them and you're going to pull out your goniometer, right? And you're going to measure those things. So you're going to be like, the MCP is 30 or greater, and the PIP is 10 degrees or greater, okay? And you're going to refer them immediately, because at that point, that is the realm where you say, okay, that contraction's been going on long enough, and now they can't put a hand into a glove, they can't grasp things, right? It's more progressive, okay? Makes sense? And we'll do the zipper type, right? The Z-type incision, right? Because nobody wants to transect any flexor tendons, right? And we'll do that Z-type incision, and we'll go in there, and we'll break those things up, and we'll reattach things. The surgery for this is not 100%. Do you get scar tissue following surgery? Yes. Can it mimic a contracture? Yes. And a nodule? Yes. So sometimes, again, surgery is not the answer, okay? Maybe multiple surgeries are needed, okay? So even if you have treatment, just because it didn't have the paresthesias, does that mean you can't involve a nerve inadvertently? Yeah, no, it does not mean that. I mean, you have to be super careful because our nerves are run through there, okay? You can have skin loss. When you make those incisions and start taking things away, right, that ability to cover those incisions may decrease, and maybe the patient will need grafts. Everybody knows what a skin graft is, right? Putting skin from somewhere else, maybe the buttocks, right? And covering areas that are gaps, okay? And it can recur. We tell people very commonly, with diffusion and contracture, they will come back. It's just what, a long enough timeline, they all come back, right? Because again, it's not known 100% why this occurs, but it has been linked again to some genetic components. My father had it, right? Okay, any questions about diffusions? So again, that's that distal palmar crease involving the proximal to that, and it's the palmar fascia. Okay? All right, good. So I'm going to burn through this because we're going to talk about fingertip stuff all like in another section as well. Okay, but stop me if I go too fast, because again, we're going to reattack certain things. Fingertip infections. Okay, you guys already, I hope, know what herpetic whitlow is, right? So you know that a whitlow is the fingertip, right? So a felon is an infection of the pulp of the fingertip. Okay, that's the pulp of the fingertip. So that's the palmar aspect of P3, as we discussed before. And it's what I'm pointing to right now, right, on my index finger. Bless you, bless you, bless you, right? So that's the felon, okay? Now, when we talk about paronychia, we're not on the palmar side, we're on the dorsal side, on the nail fold, okay? So that's paronychia, right? That's the soft tissues around the nail, okay? And that's what it's showing you there. You see that? This is the nail brand here, for lack of a better term, right? And so that paronychia can be all along there. And again, this is the pulp, okay? So how do felons occur? Usually there's some kind of puncture injury, okay? There's a puncture injury, some kind of poke. It can be acute, or it can be something that happened a week ago, and something got jammed up in there. Could it be a foreign body? Could be. Are you going to get x-rays? Of course you are. Paronychia, right? Fingernail biters. Don't raise your hand. But there's people in here that bite their fingernails. It's just a mathematical certainty based on the number of people in this room. Okay. Pickers, right? Fingernail pickers. People that go get those expensive manicures, right? Whether you need them or not. Male or female, I don't judge. Right? So, ingrown nails, hang nails, the dreaded hang nail, right? You pull on it, rip on it, it bleeds like crazy, and then a couple of days later, what gets in there? The staph and the strep, right? But what's the most common? Perfect. Do I need to hit that anymore? Okay, good. Herpetic whitlow? Well, that's a virus, right? Okay. How do you get that? Human saliva contact. Okay. You guys are on it. You know your ID. You know all that stuff. Okay, good. So felon, puncture wound, you may or may not be able to see it, but there may be a history of a puncture wound. Okay? Maybe a rose needle, right? A rose bush. They got poked, pricked a couple days ago, now they got a felon. Okay? So pulp is swollen and tense. Right? The pulp has space to expand, but remember I told you, when pus under pressure, it is painful. So at a certain point, once that pressure gets too intense, the patient will experience pain, redness, swelling. Good to go? Severe pain with tenderness, redness, and fluctuance. Fluctuance, ooey and juicy, right? Does that sound like pus? Yes. Will you guys know pus well when you get out of phase 2? Yes, because they will find you. Now, where's the PA student now? We got pus in room 4. Okay, good to go. Paronychia, depending on how you say it. All right, so you see the paronychia there? See the ooey, gooey, juicy stuff? Right, there at that rim, okay, the surrounding base of the nail. That's usually less painful, less intense than a felon. Okay, felons are painful. Okay, this is kind of less painful. Okay, so whitlow don't really talk about the pain necessarily, but we talk about what they look like. Does this look like a clear vesicle on an erythematous base? Gosh, that sounds like a pants infection, doesn't it? Yeah? Okay. All right, perfect. You'll never forget it, right? But the swelling should not extend proximal to the distal flexion crease with a felon or paronychia. That is not the same thing as the distal palmar crease, correct? We know the distal flexion crease is actually your DIP, correct? We know this because we're all smart, intelligent people, and we'll review this, okay? So it should not extend proximal, so it shouldn't come towards the wrist. If it does, that means that the infection is traveling. And we're going to talk about flexure tenosynovitis here soon, okay? So then you start being suspicious. It may not just be a felon, right? If it's on the palmar side, now you may actually have flexor tenosynovitis. Okay, radiographs, yeah, it may not show much, but if there's a concern for osteomyelitis, we already talked about that a little bit, didn't we? Yeah, we'll talk about it again, don't worry. If there's a concern, you get x-rays, are you going to see things if it's been long-standing? Yes, you're going to see bony destruction, right, erosions. So late in the course of infection, though, because you may see, if it's actually been long-standing, right, you'd be surprised, some people just don't go see the doctor, right? You can have actual partial or complete resorption of P3, of that distal phalanx, that distal bone, okay? So it can be a little piece of it, right? Or it can be the entire thing if it's been going on long enough, okay? Are you going to want to culture if there's pus present? Sure. A lot of times with the phalanx, we'll culture them, right, because that's deeper, it's a pulp. With the paronychia, is that more superficial? Yeah, so if you culture that, are you going to grow a bunch of bugs? Absolutely 100%, okay? But again, culture whenever possible, okay? CBC, CRP, ESR, we know those are inflammatory markers. We know those aren't specific for any one infection, but we're going to get these inflammatory markers to get a baseline at least, right? And see if there's improvement after we do a procedure or two, right? Or if there's worsening symptoms and whether the patient needs to be admitted, plus or minus surgical consult. Okay, osteomyelitis, right? A distal phalanx with untreated phalanx. Okay, once that occurs and that bone dies, you think it grows back? Nope, not necessarily. Maybe if it's a little bit and it's caught early on. But if that entire P3 is gone, at that point we may just take that finger past the IP, right? Not the entire finger, we're not mean. Okay, what's the bad stuff? There it is, septic tenosynovitis. That's that flexor tendon sheath. Okay, we'll talk about that specifically. That's why we're going to keep moving. Okay, so when we talk about felon, how do we treat it? Okay, you're going to make an incision, right? You're going to get to the pulse. This is describing it to you. You'll talk more about in EMED, right? Are there nerves that run on either side of each digit? Yes, and they're called digital nerves, right? Is it called the radiodigital nerve and the ulnar digital nerve? Yes, that's what they're called. So you want to be careful. You want to know your landmarks. You want to know where nerves run, and you want to make your decisions appropriately, right? I won't get too much into this. Like I said, it's not the purpose of my course. But you'll talk about this in EMED because they very commonly do those in the emergency room. Okay? But if you need to release that pus, you're going to do it. That's a felon. Okay? Right? You're going to make a stab incision, and you're going to go in there, and you're going to release that entire pulp. You see how it goes all the way through? Right? If you just make a little tiny superficial nick, do you think it's going to make any kind of a difference? No. You may not actually release that pocket of pus. Right? You may not get to it. Okay? Sometimes you got to make that incision. You got to stick an instrument there. You kind of right, and move it around a little bit and get things to kind of juice up a little bit and free flow. Get that pus out of there. If you're doing incomplete evacuation, it'll come back. All right, there you go. All right, so after you do that procedure, you're going to clean it up, right? Washy. You're going to pack it with gauze because you don't want it to just close up, right? And cause a pocket of accumulation of pus. And you're going to put a dressing on it. Okay, and you do not suture those closed. Remember we talked about how we don't want to suture things tight? Well, in this case, the incision is not quite that big, right? So you don't want to suture that nice and tight because is that going to cause a reaccumulation in a tight pocket? Yes, you don't want that. That's a principle you should never forget. Okay, all right. Paronychia, early stage, about warm, soapy soaks, right? It says warm, moist soaks. Why? Whatever. I don't know how you can soak something that's not moist, but whatever. All right, so warm, moist soaks, right? So what you're trying to do is you're trying to increase the blood flow there. That's the warm part, right? So since it's warm, what it does is it increases the blood flow there. So what it does is it gets the good things towards there, and it gets the bad things out of there. That's an increase in circulation. Okay, that's what it's doing. Okay, makes sense. 10 minutes, 4 times a day, not once a day, not twice a day. 4 times a day for at least 10 minutes. And again, warm, soapy suds, right? Warm soaps, okay? If it's severe, right, say it's involving a thumbnail, like an entire thumbnail, it keeps coming back, it's chronic, or somebody in here has probably had a toenail resection, right? Right? Somebody, it's just a numbers game. Don't raise your hand, I don't want to see it, right? But if it's bad and long enough, right, you got to get that taken off because it just keeps coming back. right? And it becomes painful, you can't wear a boot. Okay, so again, this is not, even though it's under fingertips, the same principles apply for toes. Okay, makes sense? Any questions? Okay, I know I'm moving. All right, so treatment, painful scar. We're gonna make incisions, make a scar. Okay, so there you go. The nail heal up, scar. Nail deformity, okay, if it involves a nail and we have to take the nail off, for example, can it cause, you know, with us trying to put the nail back in place after we do a procedure, sometimes it causes nail deformities. It does. So you warn your patients, you may get a nail deformity. Okay? Recurrent infection with inadequate drainage, I already talked about that. You don't get all the pus under pressure, it's coming back. Okay, that's called an incomplete evacuation. Okay? Red flags, persistent progressive swelling, especially if you're worried about septic tenosynovitis, right? It's on the palmar side. You definitely want to refer that. Evidence of hand or limb infection despite drainage and antibiotics. Don't really get too much into antibiotics just yet. We'll talk about it here in a little bit. But when it comes to this, you know, if things aren't responding to antibiotics, do you think it could be resistant to the antibiotic that they're on? Yes. So again, if you've done your best, you followed all the up-to-date, all the literature study, you did your PICO question, you looked it up, you found the answer, and it's not getting better, you got to refer that, okay? Because maybe it's something else. Good to go? Okay. So now we get into fingertip injuries and amputations. So injuries is just that, injuries of any kind. Amputations means things are missing, right? And were taken away traumatically. Okay, we're not talking about surgical amputations. We're talking about traumatic amputations. Good to go? So there's usually a history, and it may start with watch this or hold my beer. Okay? So when you're talking about it, that's it. I have pictures on my phone of multiple of these I did before I left Misawa. I don't know what it is about Misawa, right? A lot of flight line operations. Guys are operating heavy winches. They're putting trailers onto the back of trucks, right? And they get their fingers caught and crushed, okay? Or they're working with turbines and other equipment that I still don't understand to this day. They get their fingers stuck in there and they keep spinning, right? And it just rips their fingers off. It may be one or it may be multiple, okay? So the thing to understand though is the mechanism, okay? Flesh injuries, lacerations, okay? Can involve the nail and or the phalanx, right? So we need to know, if it involves a nail, right? Say it just looks like it's a superficial laceration, but it involves a nail, do we think there's a fracture underneath it? And that's the phalanx, correct? So you gotta do a complete evaluation, okay? You can't just be like, this thing, I can just suture this and send them on their way. High five, right? So do you think that they were able to reattach those fingers? Depends, right? But in the case of the person on the right, clearly they did not reattach them, right? That's not what we started with, okay? So, but there are limitations, and we'll talk about some of that. Right, inspect the fingertip for exposed bone, right? If you see bone, is that an open fracture? Okay, good. Let's go a step further. If you see a nail hanging off, right, and you get an x-ray that shows a fracture, is that an open fracture? Yes, right? Okay, so again, the definition for open fracture when it comes to fingertip injuries is a little bit looser because if it involves the phalanx, it's by definition it's an open fracture. Okay, and definitely if it involves the joint, right? The DIP, the PIP, the MCP, 100% in that case, we know that. Okay, so you want to inspect the viability of loose tissue. Okay, what we're talking about there is if it's nice pink tissue, right, and it's viable, meaning it looks like it could heal and continue to stay in place and continue to be viable, then you leave it, right? If there's areas, right, in this fingertip here, if you're inspecting this and there's areas where there's the skin that's hanging on is blue, right? Do you think that has any chance for reperfusion, for a return of blood flow to that area? No. So you take it away because it's not doing anything for you, okay? Or the patient, more importantly. Okay. So inspect the nail bed for a subungual hematoma. Subungual. Okay. So we know this term, right? Subungual, under the nail. Okay. That could be the fingernail. That could be the toenail. I will tell you this, move on, okay? If you see a subungual hematoma, so it's a collection, you see the blood there? All right, does that look like it's 50% or greater of the nail? No, I'd probably leave that in place, right? If it's 50% or greater, right, Does that mean that they have active bleeding under there and the phalanx probably poke through? Yes, right, so it's kind of a 50% rule. All right, so a lot of times I just take them off because I'm annoyed that the ER called me for this? Yes, okay, but that's not the point, right? So 50% is kind of a general rule. If you see a subungual hematoma that's 50%ish, you start thinking, I should probably take this off and explore that wound, and that just describes to you what you're looking for, correct? If you see bone poking out, you think, hello, okay, you got your answer, okay, makes sense? Because you may see the fracture on x-ray, right? Because you're like, is it poking through? No. So you go at it, so. All right, does that look normal? Nope. Hopefully they found the fingers, right? So get x-rays, understand what's involved. Because when you call somebody, when you're stationed remotely overseas or you're forward deployed with a unit, some of you guys are going back to communities, right? The person on the other end of the phone is going to ask you to describe what joints are involved. Oh, and by the way, did you find the fingers? Right? Put them on ice, et cetera, et cetera. They're going to explain to you what to do, okay? So this is not a joke. Determine the extent of the injury. Because that may determine your medevac priority and a couple other things, and also the services they have to be waiting to receive on the other end. Are we all good on that? Okay. All right, so here's the nail. All right, so the two I want you to focus on is split and hook. Right? Absent nail, that makes sense. It just never grew back. Right? But the two nail deformities that you warn people around is the hook and the split. I have a split nail. Hook nail is pretty self-explanatory, right? It looks like a hook from the lateral view. Okay? But split nail just never quite grows back and may actually have a split down the middle. Those are the two deformities. And that's what's called a dystrophic nail. Okay? That's another way of saying it. Okay? Good to go? Any questions? Okay. So all this stuff, that can be caused by anything, right? Crips, ooh, there it is. All right? Didn't I talk about how upper extremity injuries can lead to crips? So if they have a history of traumatic amputations, right, and they were treated, even if they were treated, can they develop crips? 100%. What's the drug you're going to use? Gabapentin is what I heard. Okay, good. All right, so there it is. Does that look like greater than 50% of the nail? Yep, it sure does. Do you think that's painful? Do you think that bleeding is going to cause pressure underneath the nail? Somebody here has had this, right? Okay. All right. So you see how they're using a large bore hypodermic needle, right? And they're poking into it. If you use a small one, you can poke it for days, right? You might bend the needle and actually break it. But use a large bore one, and it will actually cause a release or an evacuation of that subungual hematoma. Good to go? Looks awesome, doesn't it? Okay. You can also drill through it, right? You can do all kinds of craziness there. They make little bougies, right? It's called a bougie, right? It's a tip that heats up. You can just touch it like briefly. Don't hold it there. It will pierce all the way through and into the table, okay? All right, but you can just heat that tip up and just tappy tap, and that nail will evacuate, okay? But the principles of all these kind of fingertip injuries and amputations is to figure out what's wrong, first of all, and to come up with a goal of having soft tissue coverage. Okay, you got to be able to cover those things. You want to try to return adequate sensation, and whenever possible, you want to conserve length, right? Your ability to do this is important, correct? Even if it's only with these three fingers, because the other two are in a bucket somewhere. Okay, makes sense? All right, so you want to restore that length to try to restore function. Everybody understands what I mean by coverage? If you can't cover the wound, you can't close it, right? Just spanning the entire wound is what they're talking about, okay? Right, so when we go back to this picture here, you see this coverage here, right? They've covered that entire wound and they were able to approximate it well, okay? That's what we're talking about coverage, right? Here we go. All right, suturing, no tension or leave open, okay? What that means is those tissues, right, we talked about viability, right? Maybe tenuous viability, meaning it could come back if you still continue to die off and not remain viable. But the more tension you put on those tissues, you're strangulating the tissues. Okay, so you don't want to put a lot of tension when you're suturing. That's why I told you guys before to use the term loose approximation. Right? Don't suture things under tension. And if you think you're going to, right, and you're going to cause further harm, you leave it open. You just leave it open and let it continue draining. Okay, make sense? Wet to dry dressing with splint. Why is it wet to dry? I am not going to teach you all the nursing stuff you need to know today. But I will tell you this, if something's bleeding, right, and it dries, right, and a dressing dries to it, do you think when you pull that dressing it's going to hurt? Yes. So when it's initially draining, or wet, if you will, moist, right, you want to put a wet component to it, making direct contact with sterile saline, correct, not just tap water, right, until it closes off. And that way, when it closes off, then you can transition to dry dressings. Dry to dry dressings is just dressings, right? Make sense? Occupational therapy, do you think that I rely on them a lot for these kind of injuries? 100%, okay? They're the fingertip people, they're the finger wrist people, okay? They're the experts. I can buy them whatever beer they want, okay? Bony involvement, well, we're called ORTHO for a reason, right? Alright, what is the call phone called at the hospital some of you guys came from? The bone phone, okay? That's literally what it's called. So you call the bone phone when there's a bone involved. There you go. Okay, you're welcome. So again, principles still apply. You're going to check their tetanus, right? If they ever had their finger bitten off, right? That's a traumatic amputation by a freaking dog, right? Do you want to check rabies? Huh? Column? Oh, Gollum. Gotcha. Sorry, my brain wasn't tracking. What's ABX? Antibiotics, right? You guys know this, right? I hope. Should I use that acronym still? Really at this point? ABX is antibiotics. For grossly contaminated wounds. I already told you guys, a lot of hand injuries, we don't use antibiotics in orthopedics. Does the ER use them? They do. Does other specialties use them? They do. We are a little bit more judicious because our literature tells us different things. Let's not get too much into that. If it's dirty, though, this person's a mechanic, and they are not African American, but they look like they are from the wrist down, right? You want to use antibiotics because if they work with oils and grease and things like that, that can be a funky environment, correct? So I would just tell you if there's gross contamination, right, and despite your best efforts to do a lot of irrigation and get a lot of that gross contaminant out of there, there's still a lot of residual contamination, you want to use antibiotics. Make sense? Okay. All right. By the way I just described it, I had a person on the phone that would not get off the phone, and that was the only thing I could say that made him understand. Right? Because the person was a mechanic, and I'm like, just look at their hands. Is it dirty? If it's dirty, again, it's grossly contaminated. That's it. So, anyways, you're gonna have to find clever ways of explaining things sometimes. So, referral decisions, okay? Younger than 6 years old, right? So I will tell you this: does a younger than 6 years old have a long life ahead of them? Right? Right? So you will hear this very often in a lot of different classes. Kids, pediatrics, right? They have the ability to bounce back from injuries that adults can't. Okay, so sometimes you can do transplants. You can take toes and put them on hands, right? But do you think their ability to heal from those kind of surgeries, those transplants, is better at less than 6 years old? It is. That's where that number comes from. Okay, make sense? All right, good to go. All right, thumb. Okay, this you want to know. Okay, all right. I'm not being recorded, but you want to know this. Amputation at or proximal to the IP joint, because the thumb has no PIP or DIP, correct? You think it does? No? Okay. No, he doesn't. All right. So IP, right? So you want to say, is it proximal or distal to the IP joint? Okay. If it's proximal to the IP joint, right? So just imagine what that looks like, correct? Right? So are they able to flex at the thumb? No. Proximal to the IP joint. Okay. So you want to refer them, and hopefully we can reattach it. Does that make sense? So look for find the thumb. Good to go. Fingers, amputation proximal to the middle pause of the middle phalanx, right? So the middle aspect of P2, correct? The middle phalanx. Good to go? Okay. All right. I'm reading these on purpose. And, or if they have multiple finger amputations. So multiple finger amputations, again, you got to get someone else involved, right? Potentially a hand surgeon, somebody who's more skilled and specialized in microvascular reimplantation, okay? Because sometimes they have to put the little blood vessels back together too, not just the bones, okay? Here we go. Any questions about that? Okay, flexor tendon injuries. Okay, when it comes to flexor tendon injuries, you definitely want to focus in on this topic. Okay, because flexor tendon injuries is something that we kind of talked around, right? But I just want you guys to start understanding your anatomy, right? You guys remember from anatomy, and if you don't, I'm going to refresh you. The FDP, right? The flexor digitorum profundus is on the flexor side, correct? Palmar side. It goes all the way to P3. The flexor side of P3 inserts and allows for flexion. Okay. The FDS, the superficialis, inserts at the base of the palmar side of P2, the middle phalanx, like we just discussed. Make sense? But do you guys see where there's crossover here? See that redundancy here? Distal to the middle phalanx, the distal aspect of the middle phalanx. So depending on where the laceration occurs is what's going to be in and what's going to be out. Okay, what I mean by that is when you're testing the DIP, PIP, and MCP, are you going to isolate those and test them in isolation? Yes, and I'll go through that in the lab today, okay? But this concept you need to understand. I allegedly changed these slides to make it more clear. Okay? Look. Ring finger most common, it still falls for the same plan, right? Right? Because again, when you flex, right, that's the one that's in more contact potentially. Okay? It can occur in patients with OA and RA. What that means is they could be spontaneous ruptures of the flexor tendon. It doesn't have to be necessarily traumatic. Okay? And that's more so in RA, guys. Okay? All right. So history of trauma. All right. They're going to say they can't move it. Don't challenge me. Right? Don't challenge me. Isolate. Do testing in isolation. Don't just say I can't test them because they have pain. Because what do I hear? Challenge accepted. Okay? Make sure you numb them off first, or make sure you do a neurologic exam first. Make sure you do a neurologic exam first, okay, before you numb them off. Make sense? Okay? Because you want to check for sensation on either side of the finger, the affected finger. Okay? Make sense? This chart you need to know. Okay? I promise you, this is the first time I've done this, but I promise you you'll see this soon. Okay? So please spend some time with this. Alright? Understand if you cut it, alright, does this say that it's cut all the way through here? Or is it, I'm getting the top of Willard's head. So, sorry about that one. So is this cut in the FTP or in the FTS? No. This is saying that in zone 3, the FTP is, the FTS is cut here. Okay, so just understand that. So understand if there's a laceration to the flexor tendon at a certain level, right? What is involved and what's going to be in and what's going to be out. Make sense? MCP, PIP, and then DIP in proximal to distal order. Okay? And that's what this chart here, cleverly redone for color coding purposes, okay, is meant to illustrate for you guys. Okay? If you need me to go through this again during test review, let me know. Okay? But you need to know this. Okay? Alright, test them. Again, DIP, PIP, MCP. Alright, so you're like, okay, well it's in, but he's having a lot of pain when I ask him to do that testing in isolation. Then you start being concerned about a partial laceration. Okay? If there's pain on a proportion, and I've used that term before, correctly, then you're concerned that there may be a partial laceration. And then we get back to that 2-point discrimination. Okay? 2-point discrimination, and what's normal? Less than 5 millimeters, about the half the length of your pinky fingernail. Okay? All right, so you want to get radiographs. If you see this here, isn't that where the FDS is supposed to insert? So in this case, you have a rupture because the bone is actually fractured and that insertion has been disrupted. Do you think the management of this injury is going to be different than just a strictly flexor tendon injury? Yes, that's why you get x-rays, okay? Because you're looking for things, right? You're looking also for metallic remnants, et cetera, because a lot of people that work in machinery get these kind of injuries too, right? So you're looking for any remnants of that because you have to get that out of there too, okay? Make sense? There's the hook of the hamate, by the way. So the hook of the hamate fracture, I chose to kind of back off that one. But the hook of the hamate, basically that's on the palmar side, correct? So the hamate, we know what the bone is, right? some lovers try positions that they can't handle. Okay, I said it. Right. So when you have a hamate, it's going to be more on the ulnar side. So can that lead to a flexor tendon rupture of, let's say, their small finger? Yes. So that could be contributory. Okay. So that's important to know if you know that they have that pathology. Okay. And then RA, there it is again. RA hates you, right? You hate you. So that can cause all kinds of destruction. Okay. Loss of flexion, obviously it's out. They can't flex. Loss of strength, they can't flex. They can't grasp, right? They can't grab onto things. They can't do things. So they've lost strength. And if it involves, let's say, because this is pinch, correct? Right? If it involves the thumb, right, or the index finger, they have loss of pinch strength, correct? All right? Makes sense? That makes sense to me. Okay? So, non-operative, partial lacerations, again, common terminology tear, right? What you want to do for that is irrigation, superficial closure, right? Don't go deep. Superficial closure, right? And not tight, right? Use the term watertight, not a tight closure, right? And splint with the fingers bent. Do you think if the fingers are extended, that's continuing to allow for tension on the flexor tendon? Yes. So you want to splint them in flexion, right? So it takes that tension out of there, and if it's a partial tear, it can continue to propagate, right? Do you think we also keep them in flexion if we do a repair of that flexor tendon? Yes, we do, okay? And that's what's talking about operative, right? Repair within a week. Those will want to scar down and retract very quickly. So we want to know about those, okay? You should call those right then and there, okay? You see those custom splints? That's OT at work again, okay? Even if you treat them, they can still get infected. The repair can fail. We use different techniques for that. They're not just, simple interrupted. It's a whole other thing. It's circumferential 360-degree repairs, okay? So it's a whole different thing. These zones here, when you have laceration, right, you want to know palmar or dorsal, correct? But you also want to know what zone it's in, okay? I would say with these zones, look at your textbook, right? It may or may not give you a definition, but just understand that there are zone 2 is what's called no man's land, right? So zone 2 are especially concerning. If you take nothing away from my lecture, zone 2 is concerning. All right, so if you have a laceration in zone 2, you need to let someone know, okay? Because we call that no man's land. Okay, that's not, those aren't good. So do you think zone 2, a good way to describe is proximal to the DIP flexion crease and the and distal to the mid palm? That sounds like a good description to me, doesn't it? Is there a better way of saying that in your textbook? Probably. But just in general sense. Okay? The thumb has its own zones. I already explained to you. You guys see IP, right, the interphalangeal joint of thumb, that separates zone 1, right, so thumb 1 and thumb 2. That's your differentiator, okay? So when I talk about the IP, you're going from zone 1 to zone 2. So if there's a laceration proximal or at the IP, you can see why that's bad, right? That's not a good day. Okay. So now, whether or not they've had a flexor tendon injury, right? Maybe something punctures the flexor tendon sheath, okay, so they can get infected. Okay, so now we moved on to flexor tenosynovitis, otherwise known as septic flexor tenovitis, right? A couple of different ways of saying that. But in any case, septic tenosynovitis, I'll stick with that one. Right? So the tendon sheath extends from the DIP to the MCP joint. So all the way down, correct? And it's on the palmar side, correct? Not the dorsal side. If you call me on the phone and tell me you think you have flexor tenosynovitis, but it's all dorsal hand, I'm very confused. Happens all the time. Okay? But do you think this could be due to cat bites? Yes. Inoculations, right? Puncture wounds. Okay? So again, cat bites are infected until otherwise proven. I will watch them and wait to do the Lord's work. Okay? Does everybody understand this anatomy kind of breakdown here? Okay? Again, this is all flexor side. Okay? So 24 to 48 hours, in that short period of time, that's from the time of injury, they can develop severe pain, okay? Meaning significant, okay? You want to get a history of it, whether or not there's been an event, like a puncture wound or seeding event, and you want to evaluate the flexor side of the thumb or the affected finger. Does that look like a big swollen finger that doesn't look like probably the other fingers or the fingers of the other hand? Okay, yes. Okay. You'll hear the term sausage digit here in a second. There it is, sausage digit. I love sausage, right? Sausage is the best. I love German food, right? But sausage digit in this case is not good. Okay, so that means that the swelling is all the way around. It's not just on the flexor side, but it's also moves its way around to the extensor side too. That's not a good finding. Okay. These are called Knavel signs, guys. You need to know these. You must know Knavel signs, okay? You need to learn these, right? Okay, Knavel signs. So, the first one at the top there is that sausage digit. So you can walk in the room, sir, and take a look at that hand, right? Thank you very much. And look at it and say, that's a sausage digit, right? And that sausage digit may be held in a passive flex position, right? If you think that's contracting along the flexor tendon sheath, that's what's occurring. Okay? And when you percuss, right? He's not very giving. Oh, he is. Okay, if I'm sitting there percussing, the patient's like, oh my sweet Jesus, right? That's pain with percussion. Right? You're percussing again on the flexor side. Okay? And then when the finger was in the flex position, correct? When you go and extend the finger, right? Right? It'll be more dramatic than that. 4 to 5 stars. Okay, but basically they're going to cry bloody murder. Okay, if it's bad enough. Okay, so you should be concerned. Make sense? So I just described to you your Knavel signs. I promise you, right, that you will see something about this on pants. Okay, I promise you. I can make only certain guarantees in life. Okay, because this is just low hanging fruit. How many are there? 4. What are they called? Knavel. Sometimes I had students say I remember as Evil Knievel signs because they're all bad. I'll say, whatever works, man. You know, but I'm just telling you, none of these were good. Okay, make sense? If you have 3 out of 4, that's bad. 2 out of 4, that's bad. 1 out of 4, maybe it's early. Maybe it's early, right? But you want to watch them because you should be concerned. Good to go? Okay. All right, get X-rays, right? Because you're looking for other things. Right? There was a puncture wound. Maybe there's something still in there. Subcutaneous air. Okay, we already talked about that. Right? Foreign body. There you go. Could it be a dog tooth? Maybe it's a dog tooth that they got in there and it's still in there and it's causing infection of the flexor tendon sheath. Okay? This is limb threatening. This is another surgical emergency for orthopedics. Okay? Life, limb, or eyesight. There you go. You need to let someone know because, again, does this progress quickly? Yes. Can it progress from the finger to the palm, to the wrist, and then up the forearm? Okay? Yes. And it can happen very quickly at a certain point. Okay? So you need to get someone involved as soon as you make the diagnosis and your Knavel signs or your Evil Knievel signs are present. Okay? All right? So why would you do non-operative management of this if you say it's bad? Sometimes they present early. All right? Sometimes you can admit the patient, you can watch them, you can do IV antibiotics and see if they improve. But you're going to get all your labs? Yes, you are. Right? So you watch them. Okay? But you reevaluate them very often. 12 hours, in the grand scheme of things, that's soon, right? That's soon. So you're evaluating them again 12 hours, 24 hours. Right? You did your cultures if something's purulent, I almost said purulent, and it looks like it's something you can go after. And you're waiting for results, but otherwise you're doing empiric antibiotics and watching to see if they resolve over the next, 7 to 14 days, if you discharge them on oral antibiotics especially, okay? So operative, purulent flexor tendon synovitis, or you're watching them on the floor, right? You've done the IV antibiotics, you're watching them, you're reevaluating them every 12 hours, and then you're like, I just don't like the way this is going. We'll go in there and open up those flexor tendon sheaths and evacuate them, right? Washy, lots of fluids. And then sometimes we actually put antibiotics in there too, but we won't get into that. All right? But, like it says at the bottom there, and then it becomes urgent surgical drainage. This is not something you sit on and wait for fingers to stop falling off. All right? Or for the patient, again, systemic sepsis. Okay? So after the flexor tendon sheath has taken an injury or an insult, sometimes they get thickening of it, right? And they get stiffness of it, contracture. So even if you do the Lord's work, you do the proper treatment, they can still have residual stiffness. That's what this is saying. Good to go? Right. Any questions about this? I kind of just said this. All right. Human bites. Okay? Human bites. So I will tell you that it's basically all the same stuff I talked to you about when it comes to cat and dog bites, but the organism is different. What's the organism on the screen? Chloridins. Okay? So that's a different one. Okay? Staph and strep are still up there though, correct? So when you're talking about a fight bite, right? This is usually due to a human fight, right? So somebody punched somebody. Yes, you can get a metacarpal fracture. Yes, you can get a finger fracture. But what we're talking about is the bite itself, right? The fist make contact with the mouth, and the mouth has teeth in it, correct? So the teeth cause potentially a laceration of the extensor tendon on the extensor side. Does that make sense? So if you see an open wound, you need to test and make sure all the extensors work? Yes, right? And remember, when the patient punched the other person, right? Look at this dude's face, right? Right? So when a big member of their hand was in a certain position, so the extensor tendon was in a certain position. So this picture is describing to you that when you're testing and when you're evaluating the wound, you may need to take the patient into flexion extension as you're evaluating that wound to see if you can see where the laceration is. Make sense? That's what that picture is showing you. Okay? Don't let that picture throw you off. Take a look at it, ask questions again, and test review if you need to. Okay? Is the tooth sometimes still in the hand? Yeah, it can be in there. I literally have x-ray pictures of people's tooth in someone else's hand. Okay, you got to get that out of there. You can treat the fracture, but if they get an infection, all bets are off, right? It's not good enough. It's not, the treatment's incomplete. Okay? All right, so you guys know the signs of infection, right? So you guys know that they're going to have a history of laceration, and they may have a history of a fight. Does anybody ever admit to fighting? No. Okay, so you guys know about boxer's fractures, right? Fifth metacarpal fractures. Do you have one? No, okay. All right, so when it comes to boxer's fractures, again, you don't just get the x-ray and say, high five, I made the diagnosis, send to ortho, splint it, he'll be seen in 4 days. You gotta examine the hand and see if you see this, right? Because if you see this, it's not just a boxer's fracture, it's an open fracture. Does that make sense to you guys? Yeah? Okay, good. So, again, do a vascular exam, do a full tendon exam. Okay. If it looks like this, does that look fresh or older, chronic? Older, chronic. Okay? So, if you're looking at this, that looks like you may need to get surgery involved sooner, correct? So that doesn't look happy. Okay? Rule out ascending infection, I'll highlight that. So basically what that means is ascending infection is if you hold the hand down like this, right, in the normal anatomic position, the infection is now not moving from the knuckles necessarily, it's moved up to the wrist, the palm of the hand, into the forearm, that's ascending. Okay, there we go. I'm going to finish this topic and then we'll move on, okay? The swelling, does it occur immediately? No. What they're getting at here, though, is the swelling from the fracture can cure immediately, correct? But the swelling from the secondary subsequent infection can take a few days to come on. Okay, make sense? Okay, radiographs, again, you're looking for those boxer's fractures, those metacarpal fractures, those finger fractures. But you can't miss the concern for a foreign body as well, right? A dog tooth, a human tooth, etc. Okay? In this case, a human tooth, right? If you see pus and it's asking to be cultured, do it. All right? But if it's superficial especially, it's going to come back polymicrobial. Okay? We talked about labs, we keep talking about labs. Okay. So any of these that you guys are unclear about? Because these are the things we've talked about already. And these are always concerns for outcomes of disease if you don't get after it. Okay? Makes sense? I have seen human bites, right? They were treated in the ER as, again, a metacarpal fracture. They did the reduction, they put the splint on. The splint covers everything up, right? Can't see it. We took the splint off 2 weeks later and we're like, oh, sweet Jesus, what's going on here? Literally, the tooth was hanging out. Okay? Your body will try to push things out, correct? It may have been deeper initially, but thankfully, that patient did not get a raging infection, right? I have a picture of that somewhere. You'll never forget it, okay? So if you're going to do non-operative treatment, right, you're going to basically go in there and you're going to explore the wound and you're going to address any kind of tendinous injuries that need to be addressed. You're going to explore the wound. You're going to look for any foreign bodies. And are you going to numb the patient up before you do any of this? Please do, okay? Don't be that person, okay? And are you going to suture them tightly? Never. In the history of ever are you going to do that. I'll use some pictures, right? Even if you send them home with oral antibiotics, the work is not done. You need to see them back soon, right? Because are these people going to change potentially in the next 12 to 24 hours? Yes. So have them come back for a wound check. Okay, 24 hours it says there. Tetanus, question mark. Again, tetanus, rabies, all that stuff. This is a human, right? Humans shouldn't be running around with rabies, right? But at the same time, just make sure their immunization status has been checked, okay? Establish infection for surgical consideration. We basically do the same things, but the difference with us is if there's a fracture, for example, we'll also fix the fracture. Does that make sense? So it can be extensive or more extensive. Okay. Sometimes when you get infected, right, things start dying, and I told you that concept of non-viability or viability. If things aren't viable anymore, let's say the finger, because the infection's raging and been going for a while, we got to take it, right, to save the rest of the body, because again, the infection can be more ascending. So sometimes we have to do that, okay? All right? And the other ones you don't want to do. You don't want to give them bad antibiotics, right? Okay. Red flags, I think you guys understand this, I'm not going to read this to you. This is all the bad stuff, right? Okay? All right, let's cut it short, okay? I will see you guys after lunch.